Welcome to the deep dive, the place where we try to cut through all that noise out there. We know there's just so much information. And our goal here is really to give you that shortcut, to really get a complex topic, find those aha moments.
That feeling of discovery.
Exactly. Cut through the clutter, get to the good stuff. Okay, so let's unpack this. Today we're diving into something called BRASH Syndrome. Sounds kind of dramatic, maybe.
A bit mysterious.
It does have a bit of an ominous ring to it, yeah.
But it's this really fascinating condition, and frankly, pretty dangerous, too. It's where these, seemingly separate problems in the body, they actually team up.
They conspire, you could say.
Yeah, conspire to create this really serious sort of self-feeding problem.
And what's truly interesting, I think, about BRASH syndrome is how these factors, which, on their own might not be that severe, they come together and they trap the body in this genuine vicious cycle.
Right. So in this deep dive, we'll really shine a light on the core physiology, how that dangerous loop gets going, and really importantly, the surprisingly effective way to break it. It's a multi-pronged attack. We've pulled together quite a bit of detailed material to lay it all out clearly.
Exactly. And our promise to you, as always, is to cut through the jargon. We want to give you a clear, actionable understanding. What is BRASH syndrome? Why is it so dangerous? How is it managed? So you can walk away, really informed, but also with some genuinely interesting insights. Maybe even a new way of thinking about how complex systems interact. Okay, so first things first. The name itself, BRASH. It's actually a pretty neat acronym. Helps you remember the key bits. So B is for bradycardia. That's just a slow heart rate.
Right.
R is renal failure, kidney failure. Could be sudden or like a sudden worsening of an existing kidney problem.
Acute or acute on chronic, yeah.
Then A is AV node blocker. This refers to certain common heart meds that slow the heart down. Things like beta blockers, some calcium channel blockers.
Verapamil, diltiazem, maybe even ranolazine, potentially.
S is for shock, where the body just isn't getting enough blood flow. And finally, H is hyperkalemia, which is simply high potassium in the blood.
Right.
And the crucial thing here is it's not just like a random list of problems. It's a very specific, dangerous combo.
Exactly. And this is where the core physiology gets really interesting and shows its unique danger. It's this idea of synergistic bradycardia.
Synergistic, okay.
Yeah, so think of it like this. Usually, mild hyperkalemia, potassium that's a bit high but not sky high. It normally needs to be really severe, like over 7, maybe 7.5 millieql, to really slow the heart down significantly on its own.
Okay.
And similarly, taking your normal prescribed dose of one of those heart-slowing meds, that usually doesn't cause a profoundly slow heart rate either.
So it's not like a huge overdose or critical potassium levels necessarily? How do these two kind of mild things cause such a big issue together?
Well, this is the kicker. Here's where it gets really interesting. When these two things, even just mildly high potassium and completely normal therapeutic doses of that AV nodal blocker, when they combine, they synergize, they amplify each other's effects. And that leads to significant bradycardia, that really slow heart rate, even without crazy high potassium or a drug overdose.
Wow.
And that synergy is a key distinguishing feature of BRASH. It's like, I don't know, two small nudges that together just knock everything over.
So it's not just the slow heart rate itself, it's what happens next, right? Walk us through that domino effect, that downward spiral you mentioned.
Exactly. That bradycardia, the slow heart rate, it kicks off this dangerous spiral. So heart beats too slow, it can't pump enough blood effectively, that causes hypoperfusion.
Not enough blood flow to the organs.
Right, and that poor blood flow, it messes with the kidneys,
Yeah.
It promotes worsening renal failure because they aren't getting the blood they need to function. And then, in turn, that worsening kidney function, it makes the hyperkalemia worse because the kidneys can't get rid of potassium like they should.
Ah, okay, I see the loop forming.
And then that higher potassium level feeds back and worsens the bradycardia even more, completing this incredibly dangerous self-perpetuating loop.
Wow.
And just to add another layer, the spiral can be even worse if the patient happens to be on a beta blocker that's mainly cleared by the kidneys.
Oh, because the kidneys fail.
Exactly. The drug builds up in their system, which just accelerates the whole vicious cycle even faster. Things like atenolol, netilol are examples.
Okay, that paints a pretty scary picture. So distinguishing this from other things must be really important then.
Absolutely crucial, because the treatment approach is quite specific. Connecting this back, BRASH often involves, as we said, only mild or maybe moderate hyperkalemia. But what you see clinically is significant acute kidney injury showing up and this really prominent bradycardia.
So maybe looking at an EKG, the heart tracing.
Yes, an EKG showing that significant bradycardia, but maybe without the other classic signs of really severe hyperkalemia, like a very wide QRS complex, that can strongly suggest BRASH over just simple hyperkalemia.
Gotcha. That's a key difference.
Mhm.
And what about telling it apart from, say, someone who actually did take too much of their heart medication, like an overdose?
Right, another critical distinction. BRASH syndrome happens when patients are taking their AV blocker medication exactly as prescribed, their usual dose,
Okay.
whereas AV blocker intoxication, or overdose, involves taking an unusually large amount, way more than prescribed. Could be accidental, could be intentional.
So digging into the patient's history is key.
Very often, yeah. Finding out exactly what meds they take, how much, have there been recent changes. That history is often the main differentiator there.
Okay, so we have this vicious cycle, this BRASH syndrome. How on earth do we break it? What's the treatment philosophy here?
Well, since it is the self-feeding loop, the core idea is pretty logical, actually. You need to launch a simultaneous concerted attack on all the parts of the cycle,
All at once.
all at once. And when you do that, it's generally very effective. But there's a very common pitfall. A really common error is focusing on just one piece.
Like what?
Like maybe just trying to speed up the heart rate, maybe putting in a temporary pacemaker, a transvenous pacer. But if you only do that and ignore the potassium, ignore the kidney function, ignore the fluids,
It's not going to work as well.
far less successful. It often fails to reverse the whole syndrome. The trick really is hitting every part of the problem together, often with pretty simple, non-invasive therapies, actually.
Okay, so hitting all the components. Let's break that down. You mentioned 4 key pillars, right?
Mm-hmm.
Managing fluids,
Yeah.
treating the bradycardia, treating the hyperkalemia, and then like dealing with whatever might have kicked it off in the first place, the underlying cause.
Exactly. Those are the 4 pillars. So let's dive into that first one. Volume management, managing fluids. This is often foundational. And the thing is, a patient's fluid status can be all over the map.
Right.
Some patients might be really volume depleted. Maybe they had bad gastroenteritis, vomiting, diarrhea.
So they need fluids in.
Aggressively, they need fluid resuscitation. But then others, maybe their kidneys have been failing gradually over days. They haven't been making much urine.
You might have too much fluid on board.
Exactly, volume overloaded. And for them, you'd lean towards diuretics, those water pills, to help get rid of fluid and potassium.
So how do you tell which situation you're dealing with?
We use different tools. Bedside ultrasound, POCUS, is great, looking at the heart, the big veins like the IVC, and also just the clinical picture. Have they gained weight recently? Do they have swelling? What have they been drinking or losing? Putting it all together.
Okay, and for those folks who are dehydrated, especially if they also have that uremic acidosis we mentioned, their blood being too acidic from kidney failure, there's a specific fluid that's really good, right? Isotonic bicarbonate.
Yes, that's an excellent choice in that specific situation. It's not just plain salt water.
What makes it so good?
Well, it does a few things at once. You can give it pretty quickly. It helps correct the acidosis, the pH balance, which is great. Might even help avoid dialysis just for the acid itself.
Okay.
It also directly helps lower the potassium, partly by simple dilution, but also by shifting potassium from the blood back into the body's cells.
Oh, interesting.
And indirectly, by improving things, it helps the kidneys start working again to excrete potassium. So triple duty, really.
And then once the acid is better, or if they weren't acidic.
The other standard IV fluids, like lactated ringers, are fine.
Now, what about the overloaded patients? You mentioned diuretics.
Right. For them, just using diuretics helps manage both the high potassium and the extra fluid.
You mentioned a catch earlier.
Yes, a critical point. If the patient is actually under-resuscitated, if they're dehydrated and their organs aren't getting good blood flow, those diuretics often just won't work well. The kidneys need perfusion to respond to diuretics.
Right, you need the flow first.
Yeah.
Makes sense. Okay, pillar 2. Tackling that slow heart rate, the bradycardia. What's the main tool there?
5E calcium is usually the first go-to.
Calcium. Okay, why calcium?
Its main job here is to stabilize the heart muscle against the effects of the high potassium. It makes the heart less sensitive to the potassium, and it also acts as a bit of an antidote to those AV nodal blocking medications.
Okay. How's it given?
Usually intravenously. There are 2 forms, calcium chloride, often given through a central line, or calcium gluconate, which can be given peripherally. Standard doses, like 1 gram of chloride or 3 grams of gluconate.
And how long does it last?
That's important only about 30 to 60 minutes, so especially if the potassium is quite high, you might need to give repeat doses.
Okay. Now, what about other things we might think of for slow heart rates, like atropine? Does that work here?
Ah, the atropine trap.
Yeah.
Yeah, you really shouldn't waste your time with atropine and BRASH syndrome unless it's literally the only thing available immediately.
Why?
Well, several reasons. One, it's generally just ineffective for the type of bradycardia you see in BRASH. Two, even if it does give a little bump in heart rate, it wears off fast and you can get this rebound crash later, which is dangerous.
Mhm.
Three, you can't really titrate it easily. You just give boluses. And crucially, four, it does absolutely nothing to help with the underlying high potassium problem. Doesn't shift potassium.
Okay, so skip the atropine. What should we use then, especially if the blood pressure is low too?
Good question. If there's bradycardia and hypotension, low blood pressure, then epinephrine is a really useful frontline choice.
Epi.
Yeah, it does two key things. Increases the heart rate, obviously, but it also stimulates beta-2 receptors, which helps drive potassium back into the cells.
Oh, nice. Dual benefit.
Exactly, and it's generally safe to give through a peripheral IV line, at least initially.
Any other options?
Well, arguably a better drug, but it's often more expensive and less available, is isoproterenol.
Isoproterenol.
Yeah, it's a more potent chronotrope, meaning it boosts heart rate more strongly. And it's a pure beta agonist. It doesn't have the alpha effects that cause vasoconstriction like epinephrine does. So it just speeds up the heart and shifts potassium.
So maybe better if vasoconstriction is a worry.
Potentially, yeah. Or sometimes it works when epi isn't quite cutting it. Also safe peripherally.
Any other tricks for shifting potassium using that beta agonist effect?
Sure, if you don't have the IV meds readily or as an adjunct, even things like continuous albuterol nebulizers, like asthma treatments, can help shift potassium into cells.
Interesting. Now, you mentioned something earlier. Occult shock. What's that about? Sounds sneaky.
It is sneaky. Occult bradycardic shock. This is a really tricky situation. What happens is the heart rate is so slow that the body tries super hard to compensate by clamping down blood vessels everywhere, massive vasoconstriction.
Okay.
And this intense vasoconstriction can actually make the blood pressure reading look normal or maybe even high.
Wait, so the blood pressure looks okay, but they're still in shock.
Exactly. Because despite the number on the monitor, the heart is beating so slowly that the actual cardiac output, the amount of blood being pumped, is still dangerously low. The organs aren't getting enough perfusion.
How would you know?
You look for other signs of poor perfusion, like are their hands and feet cold and clammy? Are they making very little urine? That mismatch, okay, blood pressure, but signs of poor perfusion points towards this occult shock.
Wow. Okay, so if you suspect that, how do you treat it? You can't just give more vasoconstrictors like epi.
Precisely. That could make it worse. You need something that increases the heart rate, a positive chronotrope, but without causing more vasoconstriction. Or maybe even something that causes a bit of vasodilation.
So like that isoproterenol you mentioned.
Isoproterenol is ideal here, yeah. Because it's a pure beta agonist, no vasoconstriction. Dalbutamine is another good option. It boosts heart rate and contractility with some mild vasodilation.
And why is recognizing this so important?
Because if you miss it, and you try to give diuretics thinking the blood pressure is fine, they probably won't work. Because the kidneys still aren't getting enough blood flow due to the low cardiac output, even if the pressure reading is okay.
Exactly, and that can lead to worsening kidney failure and maybe even push the patient towards needing dialysis when they might not have otherwise.
So managing that occult shock properly is key to getting the kidneys working again.
Absolutely. And it's fascinating, we talk about pacemakers for slow heart rates.
Yeah.
But in BRASH syndrome, needing an invasive transvenous pacemaker is actually really rare, almost never needed.
Really?
Yeah. Usually aggressive medical therapy, the IV calcium, plus epinephrine or isoproterenol is enough to get the heart rate up and break the cycle. If someone with suspected BRASH truly needs pacing, it often makes you reconsider the diagnosis. Maybe something else is going on.
Okay, that's a really important point. So medical management usually wins the day. Let's move to pillar 3, hyperkalemia management, getting that potassium down.
Right, and how aggressively you treat this really needs to be tailored to the patient.
It's not one size fits all. Definitely not. It depends on, how high is the potassium, how bad is the acute kidney injury, and also how much of that isotonic bicarbonate fluid are they getting. Because remember, the bicarb itself helps lower potassium.
So mild case versus severe case would be treated differently.
For sure. Mild hyperkalemia, maybe just a bit of kidney injury. Maybe just requires optimizing their fluids and a dose or two of a diuretic once they're perfusing well. But, severe hyperkalemia, potassium over 7 or 8 with significant kidney failure, that's going to need a much more aggressive approach, maybe multiple high doses of diuretics, other potassium-lowering meds, or potentially dialysis.
And you mentioned getting diuretics to work requires a few things.
Yes, for effective kaleresis, getting rid of potassium in the urine,
Yeah.
you need a few things lined up. You need adequate volume resuscitation first, can't be dehydrated.
Yeah.
You need to reestablish good renal perfusion. That means treating the bradycardia and any shock, including that occult shock.
Yeah.
And then you give the diuretics. If you give diuretics before those first two steps are addressed,
They won't work.
they'll often fail. So fixing the fluids and the heart rate is crucial before you expect diuretics to effectively remove potassium.
Okay. And dialysis. When does that come into play?
Well, the good news is that this multimodal approach, fluids, calcium, beta agonists, diuretics, often avoids the need for dialysis. But some patients, especially those with really severe underlying kidney disease or a very severe acute injury, might just not respond sufficiently to diuretics. Their kidneys just can't make enough urine.
And
Then emergent dialysis becomes necessary to remove the potassium and manage fluid overload.
got it. Are there any other, super advanced reversal agents sometimes used?
You mean things like glucagon or high-dose insulin therapy, lipid emulsion?
Yeah, that kind of stuff.
Generally, no. Those are typically reserved for managing massive medication overdoses like a huge beta blocker or calcium channel blocker ingestion.
Yeah.
They're usually not required for standard BRASH syndrome, which involves therapeutic drug doses.
It's probably overkill here.
Usually, yes. I mean, maybe if the situation is really unclear or if standard therapies are completely failing, you might consider them as a last resort, but it's not typical for BRASH.
Okay, that makes sense. So wrapping this all up then, BRASH syndrome is just such a powerful example, isn't it? How all these body systems are linked.
Definitely.
And how these subtle synergies, mild hyperkalemia plus normal drug doses can just snowball.
Into that life-threatening vicious cycle. Yeah.
And the key takeaway for treatment seems to be that comprehensive attack, hitting all the pieces, fluids, heart rate, potassium, all at the same time.
That's the core principle for reversing it effectively, a
Yeah.
simultaneous multi-component approach. It really makes you think, stepping back from just BRASH syndrome, how might these ideas, these interacting systems, these self-feeding feedback loops, how might they give us new ways to look at other complex problems? Not just in medicine, maybe.
Yeah.
Maybe in things like ecological systems, or even, I don't know, social dynamics, where small things interact to create big, sometimes unexpected, and self-sustaining outcomes. It's an interesting thought, isn't it?
That is a really provocative thought to end on, something for all of us to mull over. Well, we really hope this deep dive has given you that shortcut, that clear understanding of this, a truly fascinating and critical condition. Keep those curious minds buzzing, and we'll catch you on the next deep dive.